Hi, and welcome back to the Capyear Cast. I'm your host, John Walkup, and today we're not only joined by Capyear's own Lindsay Manos, but we're joined by Dr. Chris Wolfgang, who is the chief of hepatobiliary and pancreatic surgery at NYU's Grossman School of Medicine. Chris, welcome to the Capyear Cast. Lindsay, good to see you again.
Thank you. Pleasure to be here.
So the interesting thing about today is we're talking about team-based care, specifically, I suppose, in a hospital surgery setting. Lindsay representing the PA side of the equation and Chris representing the physician side. So guys, let's talk about this. Lindsay, why don't you introduce the subject of team-based care and walk us through how you came to be involved with Chris's practice when you were at Hopkins?
Yeah, so the job in HPB at Hopkins was my first job out of PA school. And I love to tell a story that on the first day that I met Chris during my interview, he asked me what my 5-year plan was. And this was an interesting question because I was basically at the end of my previous 5-year plan, which was to go to PA school, get a job, and start practicing. And so this really, I think, represents what the rest of our relationship became, which was him always challenging me and encouraging me to think of, the next step and what I was going to do next. And while I laugh at that, it really set the tone for what became, a great mentor relationship throughout my clinical practice. And so I did take the job and I joined him. He really, was an exceptional leader, or what makes Chris an exceptional leader is that he applies the same high standards to everyone on his team. So when I started, he looked at what I had to offer, what I was capable of, just like his residents and junior faculty. He encouraged me to get involved in improving clinical care within the division and research, and to always strive for more. And this obviously helped me in my career, but I think set a tone for how our clinical relationship was able to really become successful. I'll let Chris speak to that as well.
Yeah, thanks, Lindsay. I mean, from my perspective, I think you're underselling, how much work it was. And I know that, I still remember that first meeting when we were in the building sitting on the bench outside the famous dome of Johns Hopkins, having that conversation. When I never really had an advanced practice before, or a physician assistant that had worked with me, in sort of a partnership. So the only thing I was thinking, and I'm glad I thought of it this way, but it was by mere chance, is I just needed some help. I wanted somebody to help me, and I wasn't thinking like, what is a physician assistant? When we interviewed people, and we interviewed many people, I looked, as Lindsay said, for the same things that I look for in anybody, and that would be like hiring a junior surgeon, in hiring or recruiting residents and fellows, is that I just wanted somebody that I could see some passion, that I could see intelligence, independence, and just had a wonderful personality. Within 10 or 15 minutes with meeting Lindsay, it was clear that that's what we had. We didn't give a lot of thought to how it would look and how we would work together. We just sort of jumped in the pool and started swimming. And, for me, of all of my talents, I think that my biggest talent is I just have an instinct for being able to pick the right people to work with. And I surrounded myself with smart people, and Lindsay being one of them, who has elevated everything that I do. I mean, the saying of you shine in reflected light is really the case with Lindsay. And so I would never be where I would be today had I not partnered with Lindsay. I know that they call, your degree physician assistant, and that's just the way it is. But I really think it should be physician partner, because that's what it is. I mean, on many levels, we are not, you're not my assistant, you're a partner. And there's many things that over the years you developed into being much better at than what I am, and have gone to you for guidance and for input on not only patient care, but my career in general. And so it has been, a remarkable run. I still wish we were working together.
Me too.
I miss her every day.
Well, so Chris, let me dig into that a little bit because as the physician, a lot of that responsibility for patient care, I mean, it all falls onto your shoulders. So when you're choosing a PA to work with you and it becomes sort of your partner, how did you go about navigating, like, all right, I'm bringing you in. Were there clear delineations as to roles, or were you just kind of a little bit more flexible and kind of seeing how?
It was well thought out and planned ahead. I sat down with Lindsay and we said, okay, this is what we got to do. How should we do this? And and then I said, I think we should do it this way. And of course, that was probably not the way to do it. And over time, it was almost like a co-evolution. I changed the way that I did things, having Lindsay there as talent, and Lindsay having it be her first job. It was great, just being intelligent and a self-starter, thought out of the box. And we sort of developed this system, to the point when we hit our stride. Lindsay was seeing about 900 patients a year on her own, running her own practice, being an academic, actually presenting at national meetings and being invited to speak at national meetings. And I was able to do my thing, and we just sort of evolved together and grew up together in a very natural way. But I don't think it was a very strategic or thought out kind of thing. What do you think, Linz?
No, I think the trust, which is really the essence of what we're talking about, I think it evolved pretty naturally, just like trust in any relationship develops. And for me, it was in the beginning, I paid attention to his interactions with everyone, patients, family members, other surgeons, staff, observed him in tumor boards. And that allowed me to draw my own conclusions about the type of person and surgeon that he was. And as he said, my role was to help him run a successful practice. And while I interacted with patients throughout their continuum, I really assumed their post-operative and surveillance care. So it was important that I trusted his judgment. That trust is critical. And because complications in medicine are always going to come up, there are always going to be very emotional conversations with patients. And so, especially in our patient population, which mostly have cancer. So my being able to truly believe that he was always doing the right thing for the patient in front of him allowed me to assume the care of those patients, counsel families through some difficult conversations, and really, just support him in everything that he did.
And and sort of the other flip side of the coin of that, from my perspective, I had things that I had to do, academically, and traveling to meetings, being in the OR 9 or 10 hours a day. It was a load off of my mind and a load off of my shoulders, knowing that I did not have to micromanage these things, that Lindsay would be taking care of patients not only as well, but probably better than I would have. So that I could do what I'm good at and Lindsay could do what she was good at. It may be unique. I think that maybe this interview extends beyond surgery, but as a surgeon and then as an academic surgeon, we have some limitations. So, I would say during the, regular, if you take a 40-hour work week, when the phones are ringing and most patients are calling, I would say 90% of those hours of that, whatever, 8 to 4 or 9 to 5 work week, I was in the operating room. And so my patients couldn't access me directly. We do long cases, of which were, sometimes 8-10 hours scrubbed on a case, and patient care never stopped. The other thing is that as an academic, we have a tripartite mission in furthering the research and teaching. And so those things were important to me. And I spent time in the lab. That didn't mean that the patients weren't important, but the research on a bigger level was to impact, and make the field as a whole better. I was able to do that because Lindsay was on the front line taking care of patients. And in fact, actually, in the days I was in the office, we would have a patient call and they would talk to our assistant, Bernadine, and they had an issue and they would say, can I talk to Lindsay? Because, they saw Lindsay as their care provider. And Bernadine would say, well, Dr. Wolfgang's in the office. Do you want to talk to him? And, no, that's okay. I think I'll talk to Lindsay because, there's a chance that she would know some of the answers to the questions better than I. So.
So that's interesting to me. I'm curious. I mean, on the communication aspect, is this something that was figured out in advance, or is this almost like on a per patient basis, and it kind of came down to who the patient preferred to talk to, or were there delineations in terms of who talks about what when it comes to patients?
Yeah, can I answer that one, Linz?
Sure.
Yeah. So I think we really functioned as a team. On clinic day is when we met our patients for the first time. And I think it was clear to a patient, they weren't just seeing me, they were seeing my partner and me. They were seeing Lindsay and me. We would be in the clinic room together talking to patients. Patient would ask a question. Sometimes Lindsay would jump in and give an answer to things where it was clear that she knew more than what I knew. So some of the nutritional aspects and stuff. And so I think from day one, the patients got the impression that we weren't just getting Chris Wolfgang, we were getting Lindsay and Chris, and that this was their care team and we were going to partner. In terms of, this is where it comes to Lindsay's intelligence. It's not like I knew more than her. It's just I had been doing it for a lot longer, and I sort of had my ways of doing it and not always the right way of doing it. She was observant and intelligent, heard what I talked about to patients. We discussed patients together after clinic. And before I knew it, she knew, almost could predict what exactly it was that I was going to say anyhow. Even in a situation, I don't know how she did it. We'd have to ask her where, we've never been over that scenario, but I think she would sit and think, well, what would Chris do in this situation? And 99% of the time it was, what I would have done. And the 1% that it wasn't, it was probably better than what I would have come up with. But that's not, saying, okay, I'm going to emulate Chris. It's like she just learned how to take care of pancreatic cancer patients. It was almost in a way sort of like a fellowship kind of thing where she learned and then probably got past the point. It's not what would Chris do? Let's just do the right thing. And then the right thing was done. And of course I would agree with it. But she became so good at it that, we often communicated but it was usually on higher level things, but we didn't have to communicate about each individual patient. She would say, for example, Joe Smith called today. It's all taken care of. He's scheduled for the OR on Thursday. I didn't have to know the details because I know that the details were taken care of. It's that sort of communication and synergism. And I think it gets back to, I had never worked really with a physician assistant. It was Lindsay's first job. And it wasn't so much I taught her or she taught me. We just sort of co-evolved into what was a system that I think was just excellent.
Right. And Lindsay, let me dig in on that a little bit on your end from your first time, working with Chris. Was it difficult for you as sort of the new person on the team to sort of assert your authority as someone who knows how to take care of patients? Being, as Chris said, I mean, he's been doing this for a lot longer. I mean, did you ever have any sort of issues sort of voicing your opinions?
No, I mean, I think in the beginning, in any PA or even resident coming out and really getting into clinical practice will tell you, you don't learn a whole lot about the nuances of hepatobiliary surgery in school. And so it really was just doing everything that I could to figure out where I could get information and how I could learn. And Chris is obviously wonderful, but it was also very clear there was a high set of standards. And so if I was going to sink or swim, and if I wanted to swim, I needed to figure out how to do that. And so I, did all the things that I had been successful doing in the past. If I encountered something, I had a question, I asked. If I didn't entirely understand, I went home, I looked it up, I read. So all of those things that we do. And again, in an academic setting, there are tumor boards, there's a lot of conferencing, discussing patients. There are a lot of opportunities that I was able to be a part of simply because of the practice setting that I was in. And over time, I was able to understand the biology of pancreas cancer and sort of the thought process behind why we're making these decisions. And Chris was always very good at talking about that or explaining that. So if I understood why the decisions were being made, then it didn't matter if it was pancreas cancer or an ampullary cancer. I could apply the concepts more broadly. And we worked together for 13 years. So over time, I saw a lot of things when it came back around. I really understood how to treat them.
If I could follow up on that, I mean, I think that Lindsay clearly wasn't coddled at all. She was thrown onto the battlefield and basically survived and came out stronger because of, like I said, the qualities that I picked: independence, intelligence, and a passion for doing the right thing. Now talking about it, it may sound like, oh, this was easy, but I'm sure it wasn't. And there was times where, it must have been tough. But again, that intelligence, passion, and work ethic, she just came out of this really being a general, and at the point where somebody that not only me, but we had a large HPB group, all of the physicians saw Lindsay as one of the leaders, not only her colleagues in, advanced practice, the other physician assistants and NPs, but us as clinicians. And it also extended beyond surgery. Lindsay had talked about the tumor boards. We would present at tumor boards often. We were in the operating room and Lindsay would present these complex patients and actually be part of the discussion and come up with a plan. On the days that we were at tumor board and I would present a patient, everybody would look at Lindsay to make sure that she agreed with that plan, and that was okay with her. Again, it just has to do with the intelligence. This may be a little bit of a unique situation. I think that no matter what Lindsay chose to do, be a physician assistant, if she chose to be a surgeon, if she chose to be in business, would just be at the top of the field because of her personal qualities and her intelligence.
Right. And so, Chris, let me put you on the spot a little bit and just, talk about the team-based approach from the physician's angle. And from everything you've said, I mean, this sounds like a real win-win, right? I mean, you've got a partner who you can rely on. You've increased your productivity, right? And so things are sort of clicking along. And I can only imagine you took this, you've grown this model with you as you moved over to NYU. And I'm curious, do you see this sort of model taking off, or are there still some resistance out there? What does it look like from a physician's point of view in terms of, trying to?
Well, I think it's like any, program that you build, personal relationship or something like that. There'll never be another Lindsay Manos. In trying to reproduce this model, I do think that this model works. Now, I would say that Lindsay is unique among any individual, physician assistant, physician, business person, in that, no matter what she did, as I said, she's going to rise to the top. But I do think that this model works and I can see it. Now, that was 13 years of working together. I'm about, a year and a half working into this new position. And, we have some new physician assistants. And in the beginning, it was a culture shock to work like this and to give them the independence. But I can see, the growth, and I can see that it has now become a more rewarding thing for them because they're not a scribe. They're not just, carrying out orders and checking off boxes. They're able to practice at the limit of their, of what they were taught to do. And I think it's rewarding. So I think it is reproducible. And I think it's really the true benefit of physician assistants. Again, I wouldn't say the name is unfortunate, but I really don't see them as a physician assistant. I see them as physician partners in care. And I think that that is a reproducible thing. When you can get that chemistry, that the patient ultimately, and that's why we're all here, is the biggest beneficiary of it. But I think on a career development, I think it's rewarding for the physician and it's rewarding for the PA or the NP, because they are really, driving patient care.
And can I add to that, John?
Please do. Yeah.
I was going to say, you asked us if we're trying to convey some secret sauce, to the listener of how you can go from having a surgeon PA relationship and really taking it to the next level. And there's another day that sort of sticks out in my mind in clinic where the medical assistant in the surgery clinic would make an announcement to tell patients how far behind each various clinic was. And there was one particular day that they announced that Chris was running 4 hours behind in clinic. And that probably seems crazy, and it is, but it was our practice was people with cancer, primarily pancreas cancer. And it was our belief that those patients should not have to wait to be seen. And so that translated into us overbooking everybody who called the office looking for an appointment into the next clinic because we wanted to help them. And that is sort of core belief of Chris and his practice. And so we operated that way, but that's really what became the catalyst to reevaluate how we did things. We couldn't ask patients, everybody, to wait 4 hours to be seen. That is annoying, and I think that everybody acknowledges that. And so we needed to do it differently. We knew we couldn't add another clinic day to the week, because if we did that, we took an OR day away, and then one less patient was having an operation each week. So we sat down and looked at, we have this patient load, we need to figure out a way to increase access to care, or we're going to increase wait times, and we had to make a decision. And that's really how we decided that I would start adding clinics at a time where he could still be in the OR. And so we decided to put acute issues that came up during the week, postoperative care, surveillance care, those sort of 3 patient populations, we moved over to my clinic. And we were able to consistently remove, I would say, 10 to 15 people a week from Chris's clinic. And so that decreased wait times in his clinic each week. It allowed us to individually spend more time with the patients we were seeing. It allowed us to actually see more people because he had all of a sudden had this capacity in his clinic. And it was very successful. It quickly became the best practice in our division and the department. And I think that's, ultimately what he's trying to replicate now at NYU. And so I think that's sort of how we did it structurally. I will say that not everybody, not all advanced practice listening, to this podcast have to say, I want to practice in that way. People, have different strengths and want to use them differently. For me, I really loved that environment. And so it worked for us.
Yeah, I think that is a great example, Lindsay. So that, I think it actually shows a bunch of things. So first of all, you had asked, did we sit down and come up with this plan? This is a plan that I never would have been able to come up with. This was something that Lindsay suggested this week. Our clinics, we were seeing 40 patients a day within, an 8-hour clinic. We were strapping the system, patients were waiting. And Lindsay, said we need to be able to do this a better way. And it was because, again, of her skills and being comfortable to be able to see patients independently, offloaded the ones that didn't necessarily have to see me on a particular day. But there was no detriment to care. I mean, they got the time that they deserved, but they saw Lindsay, on that particular visit. And, to the amount of work that it added to her. And these are actual accurate numbers, because I remember looking at when we were redesigning clinics and things, Lindsay would independently see 900 patients or so a year, in addition to what we saw together in my clinic. So on her own, that's 900, contacts or, care points of care that, just never would have been able to happen had we kept in the older system. So it just shows, again, her ability to practice independently, not a physician assistant, but a physician colleague or a physician collaborator. And just showed an example on a systematic level how she came up with something that, if it was left to the devices of the surgeons, we would not have come up with that.
I mean, that's amazing, because not only does it speak to the strong bond that you guys had as colleagues, but it also speaks to the enormous amount of trust that goes into creating this partnership just from the ground up. And so Chris, as we're sort of short on time here, I guess I want to sort of end it by just asking you, on the physician side of things, if you're speaking to a group of physicians or a physician who may have a practice and is considering going this team-based approach, which has been so helpful for you, what sort of advice would you give them?
Yeah. I mean, again, for me, pick somebody with work ethic, intelligence, and who is willing to be independent, and then don't treat them like an assistant, treat them like a colleague, and let them, practice to the level of their intelligence and capability, and it'll be a win-win situation. I think that's the biggest advice that I could give. Now, again, this wasn't that I was some, genius and able to come up with this system. I was very fortunate, and, to, by chance or by fate, to have the first person I really worked with was Lindsay. But there's folks out there who are physician assistants and NPs who are quite capable and intelligent. Empower them to do their job, and it truly will be a synergistic situation.
Great. And I suppose I can't leave it without giving one last word to Lindsay. And Lindsay, from your point of view, joining the practice, any advice for PAs as they consider, becoming part of a team-based practice?
Absolutely. And I think it's just don't sell yourself short, and what the relationship can be short. Chris is humble, but he is exceptional in his, again, willingness just to mentor everyone. And I think there are a lot of other physician and surgeons who have that same capacity, but they may not recognize that it's something that the PA or NP wants, because it's just not the traditional model. So if it is something that you are interested in, advocate for yourself, make your goals known to the physician or the surgeon, ask them for help. And I think that just making it known will help to be received well.
One final point that I would like to get across, and I know that we're talking about basically how physician assistants and NPs can integrate into a team, and and I think we talked about all of the traditional things that we would think of, but one of the things again is to not sell short our colleagues that are advanced practice. Is that after having worked with Lindsay for years and years, is that it went just beyond the clinical care of patients. Lindsay, being passionate in her field, understood that a lot of our patients, the outcome is not going to be optimal because the disease process itself there's a lot to be learned. And then she became genuinely interested in the research aspects, and started to become an expert in several fields, in particular in precancerous lesions and cystic lesions of the pancreas, and actually did original research, developed a multidisciplinary pancreatic cyst program in which she really was the leader of that program, and all of the physicians were sort of working under her, which was a huge benefit to all of the patients. But she became really a nationally, or still is, a nationally known leader on the field of cystic lesions of the pancreas. And that to me was sort of rewarding to see her develop academically into that. And the other thing too, again, is not selling your physician assistants or advanced practice short, is that for the years, Lindsay, how old are you compared to me? You're half my age, basically. We don't have to give ages, but you're half my age. And I realized this one time, it's a little bit of a funny story. We were sitting in my office at the end of the day, and I had my feet up on the desk, and I had my wingtips on, which I was explaining. I'm a very nostalgic. I hang on to everything. And I was explaining to Lindsay how these wingtip shoes, I had them when I interviewed in medical school. I had them when I interviewed in residency. And here I am as a faculty still wearing these shoes. And Lindsay said, "You realize those shoes are older than I am, don't you?" Just to give an idea in the differences of our age. But the point being is, because of her talent, she actually became an advisor to me, in leading a program. In her position, she was in the weeds and had her ears to the ground and got feedback of things that, were not going well. That, everybody, when you talk to the leader, says everything's going great. And then behind your back are complaining about things, or a situation where I thought I treated somebody fairly and, nobody complained, but had the insight in that. I think the most valuable thing, and this goes beyond her clinical skills, is probably every day at the end of the day would give me feedback on what I could be doing better, what was working. And I think that a lot of my, as being a leader, and being able to get to where I am now was because of Lindsay. She was very mature and is very mature beyond her years, truly a natural leader, somebody that I learned a lot of my leadership skills from. And still, as Lindsay will tell you, have her on speed dial when I have a situation. And although she left me and went to another place, I will still call her and ask for her advice. And go with this, and again, not looking past their as sort of taking care of patients, but what they bring to the table in terms of an entire academic service.
And then from, the advanced practice perspective, I think having a surgeon, or especially a leader of a division, and somebody who is just so excellent in their role and has a very, high leadership role, to still be open to and willing to take the perspective and sometimes constructive criticism from folks around them. That's not a quality that everybody possesses, but I think if you do find yourself in a situation where you are able to benefit from, or you have a good advanced practice, the value that can come from that relationship extends beyond just the clinical care of patients and really can enhance the whole program, because getting the perspective of the boots on the ground is really important, and that helps, the surgeon to be a better leader as well.
Right. I mean, Chris, medicine is a branch of science, right? And you talk about, the disease process. I mean, that all comes down to repeated studies and measurements, and you take what you've learned and you apply it. And so that's on one side, but on the other side, right, there comes sort of a certain personality that people associate with surgeon, which is like, hey, this is how I do it. It's my way or the highway. Are you unique in the sense that you're learning from your colleagues, or is this something that can be, taught, or is this something that people are sort of open to as the frontiers of medicine keep pushing deeper and deeper into sort of uncharted territories of science?
Great question. I think that surgeons, we all have a similar personality. As Lindsay will tell you, there's an aspect of that to me too, is that, this is the way we're going to march. And I think some of it is a practical thing. And I think that in some settings that surgeons will get a bad rap, in that, that often in the work that we do, we have to make a decision with limited data, and it has to be an immediate decision. There's no leaving it to tomorrow. So for example, if we're going to get this patient off the table, doing well, we got to make decisions now with limited information. And I think that, surgeons either gravitate toward that field because of having a personality like that, or develop that personality. But I think that outside, of that, when we sit back, we also want to make things better and in the right place in the right time. I do think there's introspection about how can we do things better, and realizing that we don't have all of the answers, is to get input from everyone. And so I think there's a time and a place. Like I said, I'm no saint. I have a lot of those qualities, as Lindsay will tell you, but I also think that there's a time where we need input from. It's all caregivers and all scientists. So
I do want to add there, because again, he is humble, but he is unique, 14, 15 years, and he is unique in his willingness to take criticism and feedback from anybody on the team, not just me. But I like to think that he also represents sort of what is a newer wave of medicine and leadership in medicine. And so I had mentioned in a previous part of the conversation how the dynamic that we developed related to clinics and autonomous practice became the best practice within our division, and also throughout the department and other areas of the hospital. And what that really means is that residents and fellows who rotated through Chris's clinic, colleagues that we worked with, saw our working relationship and the way that we divided care and really approached it as a team. And that, I think, was valuable to all of the physicians in training came through our program. And then these residents and fellows and junior faculty, they go off to their other institutions. And Chris and I have both been contacted by a large number of people asking us this very question. How did you guys develop this working relationship? How did you set this up? How can I achieve this in my own PA physician relationship? And so I think just, doing what we did every day set an example that then, he is the leader that he is, and we had the working relationship that we had, that it did set a tone, and everybody who interacted with us got a sense of what that working relationship could be at its best.
Yeah. It's, Lindsay brings up a good point, just sort of leading by example. And it is true. It was sort of, people looked at us. In some ways, we were envied a little bit. It's like, what exactly are these guys getting more resources or something, or how? It was just, I think it became clear that it was the relationship that Lindsay and I had. The only thing that I would correct Lindsay, it's not the leader I was, it's the leader, right? I do think that we led everything as a team. And like I said, to the point where my other surgeon colleagues would go to Lindsay for advice. And I think that, as we left, we can see that, I think that continues strong in sort of the culture that's there. I think that there's a lot of strong physician assistant and NP leaders in the group that are working very independently, and I think it goes back to Lindsay as a role model and the system that we built there. So I think it is something that can be replicated, and in the future will be really the standard of how people practice.
That's interesting. Great. Lindsay Manos, Cap Your Zone. Thank you very much. Dr. Chris Wolfgang of NYU Grossman School of Medicine. You guys are awesome. Thank you very much. I know you took time out of your busy schedules. We do appreciate it. And again, thank you very much for listening to the Cap Your Cast, and we'll see you next time.
Thank you, John.
Thanks, John. Thanks, Chris.